нас теперь будут два доклада на очень актуальной теме. Это тема ВИЧ-СПИДа и Universal Health Coverage. Как это по-русски вообще? Да.
Всеобщий охват услугами здравоохранения.
Доступ к лечению. Да.
Мишель, официально это называется всеобщий охват услугами здравоохранения, ВОУЗ.
ВОУЗ, да. Вот. Будем говорить ВОУЗ, да. И, в общем, здесь будет идти разговор о интеграции, идти разговор, насколько мы услышим от вас, нужно как-то идти вертикально по ВИЧ-СПИДу, по гепатиту, по туберкулезу, или насколько наше внимание к ВИЧ-СПИДу должна тоже являться как-то драйвером для усилий к универсальному доступу. Будут два спикера, и сперва я даду слово Nicole Seguy, которая вот представилась в предыдущей сессии, и которая глава ВИЧ-СПИДа в департаменте Communicable Diseases в офисе, региональном офисе ВОЗа в Копенгагене. C'est là, le verre. Oui, le gros verre. Et le petit verre pour aller en arrière.
Okay. So just to remind you that we have all signed for the Sustainable Development Goals. That is, the SDG 3.3 is about elimination of the communicable diseases by 2030, and that includes AIDS, tuberculosis, and hepatitis, and other diseases. And we also have another SDG that is about achieving universal health coverage. And that includes financial risk protection, access to quality, essential health care services, and access to effective medicines. So this is something maybe you have not heard about. This is the new kind of work plan of WHO. That is called the General Program of Work for the period of 2019 to 2023. It's to achieve the triple billion. And one of these billion is about having 1 billion people achieving universal health coverage. And the other billions are about health emergencies and enjoying better health and well-being. But you can see that these 3 billions are overlapping. So the message is that for WHO and member states now, universal health coverage is a very important focus. So what is universal health coverage? It's about all people that should have access to the needed health services of sufficient quality to be effective and without financial hardship. So basically, it's about leaving no one behind. So again, it's about getting all people included in the process. It's about giving quality services with full access and with limited or no financial input from the patient side. So we heard about in the health system that universal health coverage is about, giving services along the life cycle to women, men, infants, pregnant women. But now when we talk about HIV, hepatitis, and tuberculosis, we know that we have vulnerable population, key population, and we need them under this umbrella of universal health coverage. What we need to make sure within our program is the population who are most affected by our epidemics fit into that umbrella of universal health coverage. This is the equity component. So we have global and regional action plans for viral hepatitis, for HIV, for TB. I didn't mention TB here, but it's the same. And by the way, in the regional office in Copenhagen, the regional office for this region, we work as a joint team. It's called JTH, Joint TB HIV Hepatitis Team. This is really because we need to work together to address the three epidemics. And our plan, regional plan, called for a fast-track action to reach the targets, and they call for combination prevention and treat-all approach. And you can see that the pillars of the strategy, the three pillars in green, follow the UHC pillars. This is to give the intervention for impact, which are the tools that we know works, for example, ART, PrEP, etc. Delivering for equity is about giving access to all the population who need and may not have access now. And the third point about financing for sustainability is to sustain the funding for these three diseases. And you can see on the right, in blue, it's outside of the universal health coverage topic, but it's called innovation for acceleration. And actually, this is about implementation science. So it's just to say that implementation research is part of the key pillars of our strategies. So now what is the progress and challenging in reaching the first 90 and linking to ART in our region? I will repeat a little bit what was said in the morning, but you can see in the cascades that we have made progress. We have more people who know their status, but we still have 30% in our sub-region of people unaware of their status. We have late diagnosis. More than 50% of people living with HIV newly detected are detected late. CD4 less than 350. We have low testing uptake for key population, and it varies by countries depending on all the barriers that we were discussing in the previous session. We have still very high stigma and discrimination, not only in EECA, in EU also. It's pretty much a big problem still in the EU. And in our region, we have insufficient community-based services. We have late ART initiation, and you can see in the cascade, we have a huge drop from testing in the east of the region, EECA, from testing to ART. So why do we have this late ART loss to follow-up between testing and ART? First, we have often we have very complex testing protocols that delay the final result provision to the patient. In some countries, we do 5 tests, and then we do Western blot. And so the patient pathway to go from the community where he lives to get the final result of the Western blot can take a lot of time, and patient doesn't know how to navigate the system. So this is one of the reasons why we have a drop in the cascade for key population and for non-key population. Now, in terms of reaching the second 90, the treat-all policy has been adopted in most of the countries of the region, and we are very happy about it. We have a significant increase. Again, you can see from the last 3 years, we have a progress in terms of the ART coverage. But again, we have this major drop between testing and treatment, because the full treat-all strategy cannot be fully implemented in some countries. Procurement of drug doesn't happen in 1 month. We need to plan, we need to cost. For some countries, it's a major contribution, especially with the transition for domestic funding. And so the adaptation of the program to buying more drugs and buying new type of drugs, more potent regimen as we recommend, is taking time. And we have lost to follow-up and drop out from ART and deaths due to complex patient pathway again. So if you have TB and HIV, you have to move from one facility to another. You can be lost in the process. We still have suboptimal regimen in some countries. The NNRTI-based regimen that WHO recommend to phase out from because it takes time. So we recognize the government problem in transitioning to dolutegravir, for example. And we have comorbidity management issues, as I said, detection from moving from one place to another to be detected and then to start treatment at different places. So this is complicated, and this is one reason why we recommend the patient-centered approach, so that we don't move the patient around, but we adapt to the patient needs where the patient is. We have also, in some countries, suboptimal viral suppression. We have adherence issues for some population group, but sometimes for all population groups, because maybe we don't have enough emphasis on enhanced adherence support, enough counselors, enough support. I put a question mark on drug resistance. We have very little data on drug resistance in the region with the regimen that we are still using, NNRTI based in some countries. And it's just to give the message we need to do studies on HIV drug resistance level at national level. So this is about our targets for hepatitis. I won't give you the status as of 2018 because we don't have it. As you know, the treatment program, at least treatment part of the hepatitis program, is quite recent in terms of monitoring in our countries. And so we have to build the data system for monitoring treatment progress. But in 2015, that was the baseline of our regional plan. I just drive you through that data. In terms of prevention indicators, that is about hepatitis B vaccination coverage or blood safety, we are very close to our 2020 targets. We are doing good. In terms of injection safety, also, we are pretty on track. Now, in terms of harm reduction, as our Michel and Anna were explaining in the previous session, we are not on track because the indicator for this program is only the needle syringe exchange activities and the coverage. We are not on track, and we know that. And in terms of diagnosis and treatment of hepatitis B and C, we are making progress with the new drugs for hepatitis C. Now we can accelerate the treatment coverage, but we still have a long way to go because it's a relatively more recent program. So what are the priority actions to reach the first 90? First, we need to simplify the testing protocols in our region. And you will see that on 1st December, there will be a release of the new WHO guidelines on testing for HIV. And we already disseminated a policy brief for our region to move away from Western blot as a confirmatory test for HIV. Why? Because with a 3-test algorithm that can be rapid test or ELISA, you can get as good result as with Western blot. So the recommendation for countries is, if you want to do, you can compare your algorithm with Western blot with an algorithm with 3 consecutive tests that you can validate, first very sensitive and they're more specific, to see the difference you have. But basically, you would be able to do faster diagnosis if you use a test algorithm that would not have to use Western blot. Now you have a mix of testing approaches to pick up from depending on your epidemiology, but the message here is that it's not one or the other. You'd have to give the maximum options to reach the universal health coverage for diagnosis. So you will have, as we said, indicator condition testing in health facilities, testing for patients with STI and TB, but for population group that do not access health services because they are stigmatized or they don't want to go to the health services, you need to provide community-based testing and some newer recommendations, self-testing, partner notification, and in the new guidelines that will be released on 1st December, you will have something called a social network-based approach for testing. Basically, the idea is that for key population, even partner notification doesn't work very well because it's difficult for a drug user or an MSM to say my partner is that person because it's stigmatized and sometimes illegal behavior. So it doesn't work very well for key population. So the social network-based approach is basically to tell people who came for HIV what the testing, who are from a key population group, even if they are negative, to tell them if you can bring 3-5 people from your community, without, you don't need to be positive to ask that person, to reach out to the community to try to make them come. It's a little bit like respondent-driven sampling for when we do surveys to bring people who are not reached usually. So that's a new technique to try to reach out to key population who may not come otherwise. So again, when you do testing in the community, whether it's self-testing or testing by lay providers or peers, you have to reconfirm the test by your national algorithm, the 3-test algorithm. So it's called a test for triage. So I think everybody should be confident that when you do a test for triage and you reconfirm by the national algorithm, you should not get any problem in terms of the quality of the test result. So all this mix of approaches should be available so that people who want to attend health services, they do. People who cannot, they have access where they live. This is about the status of the self-testing implementation. Self-testing has been recommended by WHO in 2016. And you can see that now, in 2019, the dark green is where it's implemented, and the other countries in light green and even in red are lagging behind in terms of the rollout, and some do not even have a policy for self-testing. But in 2018, WHO issued this framework for implementation of self-testing because we recognize that governments and programs have difficulties to roll out because they don't know how to do it. We may understand it can be useful for certain population who need to retest regularly, but we don't know how to do it, where to put it, who pays, how we monitor. All these questions about how, we don't know. So this is the use of this framework. It gives you all the steps to plan and see where to put it, for which population, how to do, how to monitor. So the priority actions to reach the second 90 is first to understand the reasons for the late presentation and the suboptimal cascades that we have. I just give you an example. In Ukraine, they are doing something they call continuous quality improvement with the support of the WHO and the CDC PEPFAR. And basically, they're looking at the cascade, but not only the national cascade, but the cascade at decentralized level, at oblast level, and also at site level. And you cannot imagine the difference in the cascade you can get from one site to another, because the reasons for the gaps in the cascade vary, can be linked to staff of the health facility, it can be linked to community issues, it can be linked also to some national policies, but all this needs to be very granular. So like what this morning was presented by Virginie from France about how to strategize testing, for the cascade it is the same. We need to look into the small details in order to find the solution, because we have not a uniform situation for all the countries. We need to optimize ARV regimen. The transition to integrase inhibitor is very important, because now we have high level of resistance to NNRTIs. We don't know in our region, but in other regions we have. And this regimen will ensure that we have a good patient outcome for the future. We need to use fixed dose combination. Not easy for all the countries to procure fixed dose combination. We need to better address comorbidities, TB, HIV, hepatitis comorbidities, sometimes 3 diseases. We discussed about that in an integrated manner that is all about the integrated patient-centered approach. We need to improve adherence and retention by better counseling, but also for people who inject drugs, because we talk about it as key drivers of the epidemic, until and unless we provide all the services in the same place, we can't expect to have good patient outcome. So we need to have the diagnosis for the 3 diseases at the same place and the treatment at the same place for this population group at least. And we need to establish the mechanism for continuous quality improvement. You will see that after the 2020 target, maybe we'll focus more on quality for better patient outcome, and maybe, we'll see, maybe we'll focus more on the programmatic indicators for prevention also. So now the access to medicine, because this is a very important concern for the governments. Even if we want to do everything that WHO recommends, and we know what is good for the program, we have difficulties in getting the right drugs procured, because sometimes they are not registered, they're too expensive, and it varies so much depending on countries. So what happened is that many UN agencies, plus the Global Fund, plus Stop TB Partnership, also MSF Access Campaign, Medicine Patent Pool came together to work on this issue and support countries to solve the issues. And it's not only for HIV, it's for TB and hepatitis drugs also. And there was a joint declaration to improve this access to affordable quality medicines for the 3 diseases in Minsk in 2016, and we have regular meetings and consultation. And we have a joint work plan to support countries to find solutions for accessing the most affordable and quality drugs for those 3 diseases. This is very important work, and countries need to know that they can request for specific support. It's not only infectious disease program, it's health system that needs to be strengthened. So now, another things that we know works for prevention is PrEP, but you can see the status of the rollout in our region. It's also very slow. And the question is the same. There may be some political decision why we should do PrEP, but a lot of countries are struggling on the how. How do we put PrEP in place? How do we monitor PrEP? So this is just food for thought. On the left, you can see that we have the tools to eliminate the disease. We know that we have ARTs, we have direct acting antivirals for hepatitis C, we have treatment for hepatitis B, we have better drugs for TB, now including MDR-TB. We have the combination prevention and intervention, we have all of this we have. The only thing we don't have is the vaccine. So we know what works, and what works is in the WHO guidelines. The problems for the countries now is how much does it cost? Is it cost effective for me to invest in these new drugs, in this new strategy? And how am I going to put that in place? And that's where we are stuck between the recommendation timing and the actual full rollout. Sometimes it takes 10 years for some intervention to go from a recommendation that has been proven effective with all the meta-analyses and the systematic reviews of all the evidence from the world, but it's not in place because we don't know how much it will cost and we don't know how to put it in place. So this is exactly the role of implementation science, is to help understanding how to do that. What are the barriers to implement those strategies and how to put that in place? So I'm very happy that we're having this workshop today. I think it's really, I can see the momentum in the interest in doing implementation science, in understanding the barriers. And we need to go on with this discussion and support you to solve your questions on the how. So just to let you know that WHO will conduct an implementation science workshop in Berlin in February. And I think it's we all want to be complementary in this approach. We have on one side the academics, we have the programs, we have the supporting agencies, we have the donors that can fund the implementation research. I'm sure Global Fund would be very interested to contribute, and other donors. I think there is momentum to use better the evidence from the program. You have a lot of data in this region that you can use better, and you can produce additional data to understand your barriers and how to implement the evidence-based intervention. So was just to let you know that this workshop will happen, and we can get some good presentation to understand good practices in terms of implementation science in different countries of the region, and maybe draft some tentative implementation research agenda for the different countries of the region. Thank you very much.